Hello everyone, my name is Luke Wright and I'm one of the Masters of Public Health students. I've chosen to present on the ischemic heart disease in India, which according to the GDP study data is the leading cause of death amongst adults between the ages of 50 and 69 years of age. This macabre statistic is further quantified at 20.88% of all total annual deaths and is in keeping with the data published by both the Lancet and the International Journal of Epidemiology. Ischemic heart disease, which is also seen and referred to in the medical literature as coronary artery disease, involves reduced blood flow to the myocardium through the pathological process of atherosclerosis. Simplified in layman's terms, the arteries are narrowed by lipid and fat deposits causing flow-related ischemia, which then manifests as a spectrum of diseases from stable angina on the lower side all the way up to acute coronary syndromes. It is for this reason and this spectral difference that we see it being the most common subset of cardiovascular disease and the leading cause of non-communicable disease worldwide across all age brackets. The reason I've chosen this disease within this subset of the population is due to the shifting changes we are seeing in India due to industrialisation and how this is reflected in various burden of disease. Termed the epidemiological transition, we are seeing the burden of non-communicable diseases increase as infectious diseases are now being overtaken as leading causes of mortality in low-income countries. It has been established in the New England Journal of Medicine that 80% of deaths and 85% of disability that occurs from cardiovascular disease occurs into low to middle income countries. Data published by the Lancet in 2018 showed that between 1990 to 2018, there was an increase from 15.2% to 28.1% of all-cause mortality attributable to ischemic heart disease. As well as the damning mortality statistics, the burden that ischemic heart disease creates in the form of disability-adjusted life years is massive and should also be mentioned. There is estimated to be 23.8 million cases prevalent of ischemic heart disease in India in 2016, which has contributed to 14.26% of DALYs in the Indian population between the ages of 50 to 69 years of age. In regards to the impact to the country, what is the most concerning feature is that ischemic heart disease is affecting younger generations when compared to westernised countries, meaning the more functional and productive members of society are being affected and therefore the greatest economic impact in terms of gross domestic product. Estimates from the Harvard School of Public Health estimate that between 2012 and 2030, there's going to be $2.17 trillion loss attributable to cardiovascular disease as a whole within India. Data published in the Journal of the American Medical Association in 2007 suggests that an Indian population is more likely to have an acute coronary syndrome at a younger age when compared to westernised countries due to a lack of protective factors such as moderate to high intensity exercise, fruit and vegetable consumption, and then combined with the increased likelihood of dyslipidemia, smoking and diabetes status at younger age brackets. These findings have also been demonstrated in other Southern Asian nations such as Bangladesh, Nepal and Pakistan, who all have similar mortality and morbidity trends when it comes to ischemic heart disease. Using the Western countries as a reference point, I propose that the data from both the JAMA, which I just mentioned, as well as the American Heart Association, to explain these mortality and morbidity trends can be explained by, first, increased probability of risk factors such as smoking, dyslipidemia and diabetes status at younger age brackets. And secondly, by having inequitable access to hospital treatment of acute coronary syndromes, such as primary reperfusion strategies and thrombolysis, which can contribute to increased mortality and then from that, morbidity associated with the disease. The Heart Foundation of Australia outlines the risk factors for ischemic heart disease into the clinically appropriate modifiable and non-modifiable risk factors. Modifiable risk factors are those that are through appropriate prevention strategies can minimise the risk of disease and includes hypertension, smoking status, dyslipidemia, diabetes status, obesity, physical inactivity, as well as diet. Non-modifiable risk factors are those that are fixed and are associated with an increased likelihood of ischemic heart disease. They include increased age, male gender, genetic and ethnic backgrounds. For example, Maori, Pacifica people and those from southern Asian countries such as India are at higher risk of ischemic heart disease. The risk factors of ischemic heart disease is something that we as tertiary educated individuals in the first world may erroneously assume as being the basis of knowledge for most individuals within the world. Risk factors for ischemic heart disease and knowledge by the general public are variable within various populations studied, with the work of Saeed and authors demonstrating that in a hospitalized Indian population, that those with poor modifiable risk factors are more likely to have poor health literacy compared to those without risk factors. There are limitations in the data I've presented to you today, mostly owing to the restraints of health statistics in the Indian health system. Specifically, there is a lack of population-level registries and surveillance systems, which when related to monitoring ischemic heart disease makes it very difficult to create more mortality and morbidity trends as well as risk factor analysis. Additionally, India lacks a well-designed cause of death system, with the government's current installed medical certification system only covering 22% of deaths in India in 2015, with massive variabilities between the states and regions. Verbal autopsy is the most common aid used for finding cause of death.